Okay, I see it's 10:10. So welcome everyone. My name is Alexandra Korall. I am a knowledge translation specialist at Fraser Health, and I am so very pleased to welcome you today for this session as your facilitator. Before we begin, I do have a few housekeeping things to mention. So about the format, we will have two teams presenting today. The first team will start promptly at around 10:10. There'll be about a 15 to 20-minute presentation, I've been told, followed by question and answer. So question and answers will go through the questions will be submitted through the chat, and we will have about 10 minutes for questions at the end of Team One's presentation. So as a facilitator, I will be monitoring the time closely. And I just want to thank everyone in advance for supporting our timekeeping. So without further ado, I'm very pleased to introduce our first team. So I can ask both Shirley and Adeleke to, I'll hand it over to you to introduce yourselves and to start your presentation.
Thanks, Alexandra, and thank you all for joining. Shirley and I will be discussing the context in which Fraser Health's Mental Health and Substance Use Research Planning Committee came to be, and we'll provide insight into the committee's activities of about 12-month duration, including findings from evaluation activities documenting the perceived impact of the planning committee and suggested areas of improvement. We would introduce ourselves, get on in the slides. Before we get into things, I'd like to start by providing a land acknowledgement from Surrey, BC, where Fraser Health's corporate offices are located. Recognize that Fraser Health provides care on the traditional, ancestral, and unceded lands of the Coast Salish and Nkapamak nations, and is home to 32 First Nations within the Fraser Salish region. Fraser Health is dedicated to serving all Indigenous people and honors the unique cultures of the First Nations, Métis, and Inuit living within the Fraser Salish region. A bit of a disclosure before we proceed. This study was funded by a Michael Smith Health Research BC C2 grant. And here comes introductions. My name is Adeleke Fowokan, and I lead the research team at Fraser Health's Mental Health and Substance Use Program. Joining me today in presenting is Shirley Paulsen Wilson. And Shirley, I'll let you introduce yourself before we get started.
So good morning. I am a person with lived and living experience. I'm an advisor to Fraser Health, and I have other hats, but I don't work for Fraser Health. So I'll stop there for now.
And I'd like to add that Shirley was very sort of an integral part of this project. For those who are not familiar with Fraser Health, although I think this is a Fraser Health session, so everyone should be, this infographic provides some insight to the scale of our health authority. We are one of Canada's largest, in fact, fastest growing health authorities, covering a geographic area that spans about 200 kilometers, and we serve 1 in 3 British Columbians. As a program, Mental Health and Substance Use Services provides specialized services for individuals with moderate to severe needs across the lifespan. We also partner closely with other areas and other portfolios, including primary care, to integrate services for those with mild to moderate needs, toxic drug response in priority populations to address substance use and toxic drug crisis, and the Ministry of Child and Family Development to deliver child and youth mental health services. We have about 300 inpatient acute care beds, over 1,800 mental health bed-based treatments, and 13 mental health centers, and about 11 opioid agonist treatment clinics. A bit of a background around research at the Mental Health and Substance Use Program and the impetus for the formation of the research team within MHSU. Across the province, we know that there has been an increased mental health and substance use burden across all adult age groups as a result of an array of social challenges, including but not limited to the COVID-19 pandemic and the toxic drug supply emergency, which is currently in its 9th year. Driven by a need to establish a learning out system environment, and in response to the growing burden described, the research team at Mental Health and Substance Use was established in 2024 to provide broad strategic oversight for the conduct of research. A key pillar for the research team strategic framework is the need to advance patient-oriented research, ensuring that the research embarked upon reflects the priorities of people with lived and living experience. To support this, we applied for and successfully received a C2 grant to establish a patient-centered research planning committee to inform research priority setting. Over the course of the presentation, Shirley and I will describe the activities embarked upon through the duration of the planning committee and present findings from qualitative evaluation of the planning committee activities, highlighting the perceived impact and suggested areas for improvement. But first, the project commenced with a targeted recruitment phase. We recruited members by distributing promotional materials across multiple program sites and from other patient advisory committees within mental health and substance use. Additionally, a few members were also recruited using the Reach BC website. Following recruitment, we conducted initial meetings with prospective participants to mutually assess alignment, bearing in mind the full spectrum of the mental health and substance use population representation. And here are some of the posters we used in recruitment. A brief overview of the planning committee. The project lasted about 12 months. The convening activity was 9 months, while the other 3 months encompassed the initial alignment meetings and evaluation activities at the end. The committee comprised of 12 people with lived and living experience of mental health and substance use challenges across both sexes, and 2 members of the research team, so 14 in total. I'll say though that some of the monthly meetings fluctuated in terms of attendance, and committee members' ages ranged from 22 to 72 years old. The research planning convening meetings began with an introductory meeting to introduce the project objectives and to co-develop a terms of reference to guide the convening process. The terms of reference co-development was guided by patient engagement specialists from the BC Support Unit Fraser Center, and participants were encouraged through the use of prompts to provide input to key sections of the terms of reference document. The final terms of reference document included sections like shared purpose, roles and expectations, confidentiality and privacy, communication, compensation, commitment to conflict resolution, and sustainability. Shirley.
Yes, Isabel, and thank you, Lucky. Following the introductory meeting, the next committee meeting was dedicated to brainstorming research ideas together. Members were asked to come to the meeting prepared by thinking of research gaps that they would like to see advanced within the health system. Members were asked to enter in their ideas into allocated spots on the e-whiteboard in front of you, or using the Teams chat function. After the brainstorming session had concluded, the proposed ideas were reviewed by the research team, and refinements were made to phrase the ideas as questions using appropriate research question framework and/or to merge similar ideas. Changes were presented to the members at a subsequent meeting to ensure the refinements were reflected by what was initially proposed by the members. The next phase of the committee meetings was dedicated towards prioritization. We went through multiple prioritization sessions to rank the proposed lists of questions in terms of priority. Given the breadth of the responses we received from brainstorming sessions, the research ideas were first structured into 3 key categories, i.e., evidence synthesis, novel questions, evaluation-related questions. Each prioritization session focused on a key category. Prioritization was done by asking members to rate each proposed idea on a scale of 1 to 10. Mean response scores were then used to rank ideas in order of priority.
Thanks, Shirley. So here's a list of the top 10 brainstormed and prioritized research questions. I should note that the full list goes beyond the 10 questions that we included here, but for the sake of brevity, we sort of only included the top 10 questions. The question touched on themes like the effect of psychedelics on mental health, youth to adult mental health transition, links between neurodivergence and mental health, implicit biases in mental health care, effectiveness of sober space interventions in promoting long-term recovery, and so on. The full list was shared with mental health and substance use program leaders and does serve as a roadmap for the research team driving our research agenda moving forward. This concludes the first objective, which is sort of describing the activities of the mental health and substance use patient-oriented research planning committee. Now we move on to the second objective, which is self-presenting findings from qualitative evaluation, highlighting members' perspective on the committee activities, including the perceived impact of the committee and opportunities for improvement. For the evaluation, we conducted interviews with 7 members of the Research Planning Committee to explore their perspectives on the planning committee activities and processes. Interviews were conducted using Microsoft Teams and an interview guide that had been reviewed with members at one of the meetings to obtain feedback on scope. Interview data was first transcribed and reviewed in detail to develop familiarity, after which data was analyzed to describe key themes.
Okay.
Shirley?
Thank you. 4 themes were identified in the analysis of interview transcripts. They include acceptability of planning committee, impact and value, support team skills, and expertise in quality improvement. For the purposes of this presentation, we will focus on the impact and value and quality improvement themes, which highlights suggestions for areas of study improvement. In terms of the perceived impact of the Research Planning Committee, most of the respondents highlighted how their participation in the Planning Committee and the various insights the committee meetings provided helped to improve their overall perception of the mental health substance use program within Fraser Health. So the quote in front of you is, "To be honest, I feel like Fraser Health always gets a bad rap for just like the inconsistency when it came to mental health services and treatment. And I think this committee kind of painted Fraser Health in a better light for me. I really got to see how much work is happening and the other initiatives going on. So all that was really beneficial." In addition, members underscored the perceived impact of the planning committee to their own personal growth and development, and also to connection building. Some members highlighted how aspects of the meeting had reinforced important concepts or caused them to re-examine aspects of their work or personal life. Here's a quote from something to exemplify this. "I always get a lot of joy out of these groups. And when there's other patient partners present, and just me hearing their experiences and their ideas, it's kind of cool when everyone gets excited and starts building off of each other's questions and discussions." Moving on to the quality improvement theme, which provides member perspectives on aspects of the meeting that they thought could benefit from improvements. The first takeaway gleaned from interviews is that you have to be intentional about positioning the terms of reference as a framework for respectful communication as opposed to a way to police engagement. While most members loved the terms of reference and viewed it as beneficial to setting the right tone, a few members mentioned that the focus on language in the terms of reference made them worry about saying the wrong things and thus became a barrier to open engagement. The next quote to that effect: "There was a lot of concerns about proper communications and being respectful towards everyone. As long as that conversation is confined to one meeting, that's okay. But sometimes that sort of thing can just go on and take a life of its own, resulting in language compliance. It should not necessarily be about using the right words. It is about being gracious and understanding and giving people a little bit of wiggle room to make mistakes. It just makes me nervous, to be honest. I'm just like, if I say something wrong, am I going to get in trouble?" And then I kind of catastrophize. The second takeaway from the quality improvement theme is that closing the loop should be an iterative process and not a one and done activity. In particular, from a mental health and substance use standpoint, fostering meaningful closure during engagement activities aligns with trauma-informed principles. We heard recurringly during the evaluation interviews about the need for updates even beyond project completion as some of the research studies take shape. Another quote: "I will say the tricky part is that some people want to close the circle and understand what happened and where things went because sometimes we put things out there and never know how things end up. For me personally, it could be sending out regular emails or something that just closes the circle and informs people of what's happening because I think lack of closure is hard for some people. They kind of feel like they are left hanging. The final takeaway relates to the need to manage project expectations versus or via, sorry, manage project expectations via transparency. Doing this requires fully acknowledging member contributions, but also being clear about what the project limits might be. For example, in our project, the top prioritized research idea was one around psychedelics, which isn't a treatment option provided by Fraser Health. Yet the same group thought this was a line of research inquiry that was very important to explore. So, what the research team had to do was to be clear about why this wasn't something that could be pursued currently, but they also made sure to relate the urgency of the input to the mental health substance use senior leadership team.
Thank you, Shirley. In terms of future plans, work is currently ongoing to advance some of the research questions identified in the planning committee, adopting a fully integrated knowledge translation approach. So, for example, we've partnered with 3 members from the research planning committee who will sort of act as advisory members on a various synthesis, exploring factors affecting child and youth to adult mental health transition. Shirley?
So, thank you. To conclude, the meaningful inclusion of people with lived and living experiences in the health system research planning can help to ensure that research priorities fully reflect the lived realities of those most impacted by the system. However, it is important to ensure that approaches to the engagement of people with lived and living experience in research planning are adaptive and feedback driven, allowing for real-time adjustments that help to address potential barriers to meaningful engagement.
I also just want to take a moment of time to acknowledge the contributions of the following individuals, especially the committee members, for their contribution and commitment to this project. Thank you. I suppose questions now.
Thank you so much, Leke and Shirley. That was such a wonderful presentation, and I love hearing about how priority setting is underway in your department, and it's just fascinating. So we do have a question that's already come in. It's thanks for your presentation. Could you share more about who the people were that submitted research ideas in the brainstorming session? How do they represent the diverse care needs in mental health and substance use?
Yeah, so we were intentional about ensuring that the folks we recruited were members we lived within the Fraser region, and we did that through recruitment from Fraser programs, as I mentioned, but also mental health and substance use does have some regional advisory committees that's patient-led, and so we also recruited from those some of those committees as well. And we did some targeted recruitment to younger folks to ensure that we had folks that could across the full spectrum of ages that mental health and substance use provides care to, but also ensuring that mental health partners and substance use partners were included within the committee. So I think it was mostly very targeted in terms of our approach to recruitment. And these folks were the same folks that who comprised of the patient research planning committee, but also the folks who provided ideas that were in the brainstorming sessions.
Can I just add that it was a very diverse cross-section of both patient partners and family partners within the mental health and substance use spectrum. And it was this particular group that actually fed the ideas into the brainstorming. It wasn't staff, it was the people with lived experience.
We don't have any other questions in the chat, but I have a few if you don't mind.
Go for it.
Oh, actually, one just a comment that came in. Thank you so much for sharing your experiences, Adeleke and Shirley. I'm a graduate student in psychology and currently putting together a POR project, which is a patient-oriented research project. The quality improvement section was very insightful for me. So just a thank you.
Thank you.
one of my questions that I have is, do you have any plans to repeat this process? So I know that this was undertaken as part of setting up your research department, but as we all know, it's unclear how long research priorities remain valid. So is there plans in the future to revisit?
Yeah, yeah, and Shirley can attest to it. The initial plan was to make the grant was supposed to be a proof of concept that this works, and then following that, we were going to see if we could secure long-term funding for this within the organization, or if not, we could apply for more grants. I think the plan to secure long-term funding, it's probably not the most feasible option now, just given the current situation of things. So yes, we plan to possibly apply for further grants to maybe expand some of this work. Maybe not in the way we did it now, because we do have a long list of research projects that we still need to check on from the list of questions that we provided to us. So maybe in a different way, but sometimes, but I do think that we have plans to extend this further if we get the right funding for this.
Thank you. I have one more question if you're all right with it. So I saw your list of research questions, and I'm familiar with the process called the James Lind Alliance, which is a formal process for research priority setting. And as part of that process, there's typically sort of a vetting mechanism that goes in place where basically you look to see if any of these questions have already been answered by research. And if instead this is more of a knowledge translation problem, I'm wondering if any of the questions might be more knowledge gaps that you could consider, doing some targeted efforts around implementation and knowledge translation as opposed to research.
So yeah, what we did was when we compiled the list of questions, we did check the literature to see if these were questions that were already answered, in which case maybe we explore them through an evidence synthesis approach as opposed to a novel research question, which is why Shirley mentioned we categorize questions into three different categories. So questions that are relatively novel that we had not seen before in the literature, questions that we had seen before, but maybe we could do like a vigorous review in this case, which we are pursuing one currently, but also other sort of forms of evidence synthesis as well. So I would say we explore that. But in terms of implementation, no, we've not. Obviously, just given the nature of our implementation project work, they're heavily funding reliant and stuff. And so I think on our side, we wanted to pick questions that we could easily answer without sort of applying for large scale funding. And as obviously as other funding opportunities become available, we plan to explore some of these projects using those opportunities as well.
I just want to add, I think it's really important that those of us that were providing the input and ideas for this, that the ideas were compilated and then sent back to the research team to bring it back in a formula that would actually work for us to prioritize before going back to the research team. And I think that why that's important is because these are real live situations, active even, where people are like, what are you doing? How are you doing it? Why are you doing it? So it came from the voices of the lived and living experience.
Yes. Okay, well, thank you so much, Adeleke and Shirley, for your wonderful presentation. If there are no more questions, I would now ask the second team to present.
I should note, I just got an email from a message from Dr. Puri saying they have not received the link yet. So I'm just about to send it to them. So there might be a bit of a delay there, just
Okay,
FYI.
thank you, Leke. I'm wondering if Tyler could also assist. He's our tech support person
Hi,
today. Hi.
what is the problem right now?
Our
Uh,
second team is having difficulty accessing the link to join.
Okay, let me try and fix this.
Okay. I need to bounce off to another meeting,
Okay,
but I will watch when the recordings come out. Thank you. Thank you for hosting us, Lucky. Thank you as always, and we'll connect afterwards.
and
thank you.
thank you for your contributions to this, Shaggy. We'll talk afterwards. Yeah.
Thank you.
Well, Adeleke, if you don't mind, I have a few more questions if you want to keep the discussion open.
Yeah.
Yeah. So what were some of the main challenges you faced in sort of starting this process, and how did you overcome those?
I think scheduling was a big part of it, right? And when most people joined, they were at a different phase of their life. And for a project that spans about a year, at some point we got into sort of a part of the project where people who maybe wouldn't have jobs when this project started at jobs, and so they couldn't quite work with the sort of schedule that we had planned moving forward. Some of that was an issue. I think it speaks to the natural sort of attrition that is I guess plagues long-term projects. We tried to, in the beginning, expand the recruitment list to ensure that the number of folks that we recruited was more than we initially expected. Just in case if folks dropped out, we still had a bit of a buffer to support dropout. So I think that's how we addressed it, by over recruiting in the beginning, such that when they were dropouts, we're still fine midway through the project.
Okay, thank you, Adeleke.